Thank you for joining us. My name is Russell Hendrickson. I'm the CEO at Practical Data Solutions. Today's topic, Modeling Medicare 2021 Proposed Changes, and I'm pleased to have Scott Everett, our Vice President of Healthcare Solutions, joining me today to carry us through most of the content here.
Thanks, Russ. Thanks for joining us today, everybody. For those of you who are unfamiliar with Practical Data Solutions, for about the past 20 years, we've become an industry leader in really taking analytics and visualized information and putting it into the hands of the people who need it to run the business of healthcare.
So when we talk about analytics, it would be great, especially with what Medicare has proposed in 2021, that we could just magically click on a visualization, something like what you see on the screen, where I can just point and click and start to understand what procedures are going to be impacted, how is our revenue going to change, what's the impact to if we have different divisions or specialties, and really be wonderful if the analytics would just sort of magically happen at my fingertips like you're seeing on the screen. And that's really the subject of today's webinar, is how do we use the analytics technology to understand and plan for the changes that are coming.
Yeah, so I'm sure you guys have heard at the beginning of August, CMS came out with their proposal for the 2021 physician fee schedule, and there's a rule that came along with that. If you want to read it, it's about 1,350 pages, but I mean, most of it's charts. But there's a lot in there to look at. The thing is there are some significant changes that came along with this particular policy and rule that are more significant than what you would see in a typical year. To give you kind of a high level, or at least the major talking points of what's going on, what it involved is a revaluation of the work RVU components of some common E&M codes. People have felt that these have been kind of underpaid and undervalued for a long time. And so they put a lot of effort and time into revaluing those codes. In addition to that, there are some changes to the way that they calculate the practice expense RVUs. But the biggest change that people are going to notice and are receiving the most comments right now is the decrease in the conversion factor from this year being 3608 to 3226. That's a significant drop in the conversion factor of almost 11%.
And Scott, if I'm not mistaken, the last time we saw a conversion factor in that $32 range was almost 20 years ago.
Yeah, I've been around for about 20 years in healthcare, and I don't remember ever seeing it below 34. So this is definitely an interesting thing we need to look at, but it's not all terrible. So we'll take a look at some examples and show how it's going to impact things. Before we really dig into that, though, for those who are unfamiliar with the way CMS reimburses, each procedure code is assigned an RVU value, and an RVU, total RVU, is made up of three components based upon the effort of the provider, the expense or anticipated expense that the practice incurs for doing this, and then the risk that they assume for doing it as well. So if you sum those three components together, it gives you a total RVU for every single procedure code that's performed by a physician. Now, every year, based upon budgetary considerations, they put forth an RVU conversion factor. It does change every year, but usually it's only a few cents here or there, depending upon what's going on from a budgetary standpoint. When you take that conversion factor and you multiply it by the total RVU, that's what gives you the approved amount for Medicare, basically what Medicare reimburses for each individual CPT code. Obviously, it's a little more complex than this based upon site of service rules and modifier adjustments and provider types, but in essence, this is how CMS reimburses for each procedure.
So Scott, if I understand correctly from what you said earlier, we're going to see an increase in reimbursement codes for our evaluation and management codes. So reimbursement is going to go up here. But because that conversion factor is going down, we're going to see lower reimbursement on virtually all other procedures, anything that is a non-E&M code that's been raised. Is that correct?
For the most part. There are other procedures that are impacted, as there always are every year. They change RVU values here and there for certain things. And actually, while we're talking about E&M codes, it's not really all E&M codes that are going to be increased. It's really mostly just the highest volume ones, the new patient office visit and the established patient office visits, that are getting the big bump in the RVU changes. So really, like I said, let's go in and we'll take a look. So here are those evaluation and management codes that are impacted. These are the real high volume codes, and for most practices that are multi-specialty, these are going to be the highest volume codes that they're going to see. So you have your 99201 through 205, which is your new patient codes, and then you have your 211 through your 215, which are established patient office visit codes. Now, each of these are receiving a bump in RVUs. Your new patient codes are getting a smaller bump, right around 10%, on your higher level codes. So you'll see the 203 through 205. But where you're getting the big bump is in the 99212 through the 215, which are receiving about a 30% increase in their RVU values. Now, that's a pretty significant difference. Let's go in and take a look at how that's going to play with the change in the conversion factor. So let's take, for example, a 99213, which is basically a middle level established patient office visit. In 2020, the work RVU for that was a 0.97, and the total RVU was a 2.11. And when you multiply that out by the conversion factor of 3608, that gave you a reimbursement for that code of about $76.13. So in 2021, the change came so that the work RVU is 1.3 and the total RVU jumps up to a 2.44. Now, even with the lower conversion factor of that 3226, the increase in RVUs made it enough so that there's an increase of about $2.50 each time you do this code. And now that doesn't seem like a lot, I know, but when you consider that a lot of larger practices are doing thousands upon thousands of these every single year, that can be a pretty significant increase in RVU evaluation.
So Scott, it would seem that all the codes that are being increased, the E&M codes, we should then see a gain on those codes. Is that correct?
Not necessarily. So the new patient codes actually didn't increase as much as the other ones did. So if we look here in the 2020 for a 99205, that's the highest level new patient office visit. Based upon 2020 valuation, the total reimbursement was about $211. Well, in 2021, the RVUs did increase, and they increased by a decent amount. However, based upon the reduced conversion factor and the number of RVUs involved, it actually drops to $199. So about a $12 drop when we see that. So this is what we're talking about when we say that each code is going to be impacted a little bit differently. And obviously, if we get into the codes that aren't impacted with an RVU increase at all, that's where the rubber really hits the road. So if we look at a common code, a surgical code like a knee arthroscopy, in 2020, it's a fairly significant total RVU of 15.24, bringing a reimbursement of $549.85. Well, the RVUs didn't go down, but the conversion factor drops that total reimbursement down by almost $60 each time this procedure is being done.
Yeah, that's significant. What's interesting is in the past, normally we would see RVUs go up or down, and the conversion factor typically would increase a little bit. In this case, by changing both the conversion factor and not changing the RVUs, it would almost appear it's, oh, well, the RVUs are the same, right? But the net effect is a reduction in payment. So we've got a lot of different codes, organizations, obviously different specialists, just about everybody in primary care, even specialties, do E&M codes, but how do we understand the impact of the organization? Because you're talking about a couple different things shifting here, not just the RVUs shifting, but the reimbursement factor shifting. So how do we go about analyzing this, Scott?
Well, really, it's going to be different for everybody that's out there. It's going to be different for the practice. It's going to be different at a department level, very different at a specialty level. And we want to be able to understand how it impacts everybody. And if we can, we'd probably like to break it down even at a provider level. Okay, so this is a dashboard that I put together trying to understand. The first thing we want to do is we want to make sure that we understand how this is going to impact our organizational reimbursement from Medicare. And the way I did this is I pulled all of the E&M codes that I had done year to date, starting in 2020, and I revalued those. So I put the new RVU values on those so that I understood at each level how much our RVUs are going to increase. The next step that I did is I pulled my 2020 work and total RVU for my Medicare services, and then I added in the E&M differential that was there so that I came up with a projected work and total RVU. Now, once I had that, I was able to go in and understanding the 2020 RVU conversion factor, I was able to come out with kind of a projected reimbursement for 2020 Medicare based upon what we had done year to date. I took then my projected total RVUs, multiplied it by the new conversion factor, and came up with the projected reimbursement. So you can see the difference between what was projected for 2020 and what's projected for 2021 if we did exactly the same thing. Now, obviously, like I said, this is going to be different for everybody, but understanding it at the highest level of the organization is where we really want to start.
So, Scott, then, obviously we're seeing an increase. That would appear to be a good thing, right? In terms of understanding, okay, so revenue should go up in spite of the fact that the reimbursement, the conversion factor has gone down. But how do we begin to understand the impact of different departments and the divisions here? Because I'm looking over here on the right side of the screen, and I'm seeing certain specialties, primary care going quite up, but how do we handle and factor in the other departments?
You're going to see winners and losers based upon the type of services that each specialty provides. And depending upon the number of providers and the number of codes that are done in the individual service mix of your organization, you're going to be impacted a little bit differently. So you can see here, obviously, places like internal medicine, family practice, even endocrinology, all of those are going to increase in their services that you'll see. When you see more hybrid ones like cardiology or gastroenterology and even your maybe surgical specialties, those are going to take a little bit bigger hit on this coming from Medicare, where that goes.
And Scott, obviously different organizations, their percentage of Medicare, not just within the department, but as a total mix of their payer mix is going to vary. So I know you modeled out here, let me add this to the screen. What's the impact of Medicare's mix then on our reimbursement in total, factoring in Medicare as a percentage of our total payers?
Right. You may have other payers that are going to be impacted by this. Most payers' reimbursement won't change. However, from an organizational standpoint, I really do want to see how this Medicare change is going to impact us, how anyone else's change is going to impact us. I really want to be able to model and project that out to make sure that I can tell the story and that anybody who's maintaining the budgets is getting the proper information.
I just want to note we have about half the audience on the call today are PDS customers. Most of them use the PDS Dash software tool. This is a design that we've modeled out and we'll be having a workshop on. So if you're a PDS customer using that tool and you'd like to get the template and learn how to use it, we have a workshop. I'll talk more about that coming up at the end of the webinar. Moving forward a little bit, let's go back to that visualization that I briefly showed on the screen to start. This is very similar analysis that's now been built out in our analytics to handle looking at the impact, right, the proposed, what we did this year for Medicare, and then what we expect if we do the same thing next year, how would that model out? So this is a visualization where we've modeled the procedures. We've measured the impact as either a gain or a loss, so we can quickly point, click, and highlight and understand what's changing. We also then have the same divisional, which, you know, in a multi-specialty organization, you're going to have to factor in budgets. We'll talk about that and try to account for, is this a win for the organization as a whole, but how do we handle the individual physicians or the changes as such? So, Scott, here we have analytics. It's modeled out that change. What do we do from here?
Well, I think the first thing you're going to notice on here, at least people who would be opening this report, the first thing that's going to draw their eye is that proposed impact by specialty. So again, you can see cardiology, which is kind of a hybrid procedural and office visit type places, is looking at a slight increase in overall reimbursement that's coming through. Gastro is seeing that as well. However, if you look at something like orthopedics, things like that, then you're going to see that the proposal is going to be a little bit less than what you're expecting, or at least what you're hoping for. What you'll see over on the side as well is understanding that there are going to be changes to all of the codes a little bit differently. Medicare is not just focusing on these E&M codes. Every single code has some changes. It's just most of those are lower volume codes, and the changes aren't as significant as they are becoming on the particular E&M codes that we're looking at here today.
And so to really get in and start to do this procedural level analysis and understand, obviously we need a good set of analytics. The way we've modeled this out, you can certainly take and then drill into. So I could move from our visualization into cross-tab type report. I could continue to slice and dice through this report. In this case, we've done a little projecting both for what this year looks like and potentially if you've modeled this through, when we start booking revenue in January and February and March, there's a couple of key things that we might want to look at, and I want to just highlight here. So if we start to look at, say, a particular department and we want to get down to the physician level, you'll notice here that our RVUs seem to be going up in next year, obviously because of what we would expect, but we can recalculate the RVUs in 2021 to equal 2020, so we can really start to understand, is this really an increase in RVU productivity due to volume? Or is this just because of the way Medicare has changed their reimbursement and the RVU values? And from here, I can continue to slice and dice right through the detail on this and drill in. So again, if your analytics are staged appropriately, I can just point and click and drag and drop, and I can drill all the way down to the detail. Having our analytics staged, doing this at the procedure level, and then obviously that gives us the power we need to slice and dice through the data. So let's assume we've done our analysis, Scott. We can do the analysis. We've got our different tool sets to run our analysis. We can dig in. What do we do now? How do we work our way through preparing for the change and even then measure and monitoring the change?
Well, we went through and did the change in the Medicare reimbursement, but I think it's important to understand that's not the only thing that's going to be impacted by this. Payer reimbursement's not going to change, or your commercial payer, most of your commercial payers won't change by this, but RVU values are pretty universal. RVUs are what's utilized to calculate provider productivity, provider compensation, budgets, things like that. And so it's really important that we're planning ahead and understanding this RVU impact and what it's going to mean for a wide variety of things that are really important to the organization.
So let's go ahead and take a look at a physician dashboard. Many organizations publish or show something similar to this. So in this case, kind of typical physician dashboard, we've got charges, payments, adjustments, simple trended by month. Of course, this middle section, we're looking at RVU productivity. We might be measuring the physicians against the benchmark to measure how is their performance compared to peers or national standards, right? We might be adjusting for clinical FTE if we're an academic medical center or have part-time physicians, and then measuring things like charge lag, billing lag, payer mix. So this dashboard, which may be working today in our environment, what do we have to do? Does this work, Scott, for where we're headed with this change?
So there's one thing right now that really stands out to me that's not working really well, and that's the comparison of the work RVU productivity to benchmark. Now, most benchmarks lag behind a little bit on the collection of data that they use to calculate their averages and percentiles and things like that. So comparing to a national benchmark with a huge change in RVU values for very, very high volume codes, you're not getting an apples to apples comparison. And depending upon the organization that you use, you may not have a good new benchmark for another 6 months to a year. What you probably want to be able to do is go back in and almost do the reverse of what we did for the projection of the RVUs, where you say, here's what our actual RVUs are. Let's back out the changes so that we understand, are the increases that we're seeing in RVU productivity in our areas above the benchmark, are those just attributable to the change in RVU values, or are those attributable to an increase in provider productivity? So looking at the graph like this might tell a better story both to the provider and to the medical director in terms of, are providers actually being more productive, or are they just getting that artificial increase in the RVU value?
A great opportunity, as you think about making these changes and think about designing what reports you're handing out, great opportunity to take advantage of some new designs or new technology, refreshing those dashboards and making sure that what you're providing is meaningful. To me, if you just continue measuring productivity, as you point out here, Scott, it's pretty obvious, right? You're sending the message, hey, you're doing a great job, when in fact they might still be below what is a benchmark, but we may not know what those benchmarks are for some time. Great example is something to consider. Let's look at another example. Many of our customers use something like this, and many healthcare organizations looking at outliers. This is something we call a performance opportunity dashboard, where we're measuring physicians' productivity. We're measuring that against the division or department average. So we're looking at things, what we call activity here. What are their collections? What are the total generated work RVUs? what's their reimbursement per work RVU. Again, if we need to adjust for clinical FTE, we can build that into our dashboard and even then impute what is the activity and the clinical FTE the physician is performing at. So there's our activity section. Here we're then comparing them to everybody being a full-time equivalent, so we can build what is the division RVU benchmark, and then how's the physician performing, and then of course bringing in that external benchmark that we just talked about. So this dashboard then allows us to model what if everybody improved by 5%, what if everybody moved to their reported clinical FTE, or what if everybody who's performing below the division average, in this case 4,341, moved their RVU productivity up, how much more revenue might we see? So this is, whether you do it like this or you do it in a visualization, but the results are the same. Scott, what do we have to do here? Does this type of dashboard need adjustment as we head into 2021, given what we're seeing from Medicare?
Well, yeah, I mean, we talked before about how those national specialty averages aren't really holding water anymore. Again, it's not an apples to apples comparison. That said, a dashboard like this still has value. If you take out those national specialty averages, there's still value in comparing the provider against himself or herself and the opportunity at a 5% increase or to actually work at the reported CFTE level, or comparing a provider to an internal division. Those are giving you apples to apples comparisons. Those are definitely ones that are still available to you and help you to identify where there are opportunities for improved performance or enhanced productivity.
That makes sense. Let's look at an area that I think is a big concern if you think about these changes, which is physician compensation. And again, this is a dashboard. Many clients have similar based comp plans. This is a representative, but in our modeled comp plan here in this dashboard, we're looking at RVU production accounting for 90% of the physician's comp, right? With some additional incentive pool based on quality scores or patient satisfaction scores or patient access scores. So this type of dashboard, again, if your current comp plans run something similar here, Scott, what would you recommend? And let's dig into how do we both change what we would show or model, and then how we're going to model that data out.
Right. So what you're looking at here, the thing that really is going to cause heartburn for a lot of CFOs is going to be that RVU piece again. When we look at it, like we said, that reimbursement is only impacting Medicare, but the RVUs are impacting everything. So if we have a plan that's based heavily upon RVU factors, those are just going to go up, and they may go up without any sort of significant increase in the productivity levels of the providers themselves. And heaven forbid they're in a tier process where a provider could just be doing the same amount of work but jump a tier just because of the change in the RVU values that came from CMS. Now, sometimes you can change these, sometimes contractually you cannot. Either way, you're going to want to be able to know and model this information in order to be able to accommodate that from a budgetary standpoint.
So let's go ahead and take a look at more complex visualization where we're modeling compensation, both expected compensation at year end and then projected compensation, assuming that each physician, the departments are doing the same amount of work. Now, I want to just stress here, when we start talking about modeled physician compensation, most organizations, if they've ever tried to tackle fully automating comp, can be quite challenging given the one-off unique nature of some of the comp plans. But I do want to stress that doesn't mean you can't load your calculated comp into your visualization tools and do this type of analysis. And that's what we're doing right here. So we're showing the actual comp. We're then projecting adjustments to comp based on the changes in RVUs. And then we're lining that up against the projected revenue change by department based on the reimbursement change from Medicare. We're then showing the individual detail by physician and looking for, if you will, the winners and the losers, where their variance, and then we're trying to graph that out on a scattergram. So Scott, let's take what you were just talking about, remodeling comp, and the first step usually is understanding what is this impact from Medicare and how is it going to impact the physicians and the various divisions.
Yeah, so the way we built out this model was by taking a common variable, which is RVU productivity, that it extends to both reimbursement as well as comp. And what we wanted to do is we wanted to, again, kind of highlight the winners and the losers as far as where they go and what we're going to expect. And you can see over in that bubble chart, we have all of our providers, and you can see the ones who are going to see an increase in their productivity. or increase in their reimbursement per RVU. And as you would expect, they're going to come into family and practice and internal medicine. Now, in the upper left, you see their expected increases in compensation that come from that, but those are balanced out by an increase in the revenues. The problem that we have with that is that when we look at maybe our higher volume RVU providers, those are going to be our more highly compensated ones. And a lot of times those are coming from specialties that are not heavily office visit or E&M based. So if we look at the higher volume ones, you'll see most of the ones that are going to see the bigger decrease in the change in RVU, payment per RVU. Again, there's an expected increase in compensation that's coming from that. But in cardiology, if you look down in the lower right, revenue is anticipated to be flat, and in orthopedics, it's dropping. Again, that there may not be a lot you can do about it based upon your provider contracts, but if it's possible to modify it, you may want to look into that. And if it's not, you at least need to, again, make sure you're accommodating for the changes that are going to be coming from this.
I think this is a big area when you think about forecasting revenue and budgeting that you really need to look very closely at. And this, obviously, this model here we're showing on the screen, this isn't real data, but it's certainly representative of the type of analysis that you may want to consider doing. Again, if you're a PDS customer and you're on the call, we have a workshop geared around how to modify your analytics to look at projected changes in both RVUs and reimbursement, and we'll have more details on how you can attend that session and learn more. Shifting gears just a little bit, Scott, I know in the past, anytime we have significant changes from the payers, it's very important that we're able to manage the compliance of the payer paying us and ensuring that the payer got the new contract set up. In this case, changes from Medicare, changes at the clearinghouses, changes in remittance, we're sort of taking for granted, but I did want to just highlight you should be able to do through your analytics, the ability to click and understand if you're being underpaid or reimbursed at a procedure level, at a lower payment level. We've had some webinars on this in the past, but I'll just again show a very quick visualization. Many of our clients, if you have our contract analysis module, you can do this type of analysis where you can very quickly start to see which procedures are being either underpaid. You can slice and dice through the payers, not just Medicare, and start to understand where there are potentially opportunities for you to recover reimbursement. If you don't have a tool set that's as automated or as easy to use, certainly we'd love to talk to you further about that as well. Just a little bit on the analytics here. Scott, anything you might want to add about when the changes kick in January that we might want to be watching or monitoring for?
Yeah, again, these are big changes, and most of the time it's fairly easy for the clearinghouses to accommodate those, or the changes are so minor that by the time they do, it's important. You haven't lost that much, but it's really critical that we're monitoring what's going on with the clearinghouses and the people who are processing these claims to make sure that they have everything loaded accurately and we're getting what we would expect. In addition to that, you may have some payers, not common, but there may be some payers who are based upon a current year Medicare, so you'd want to make sure you're monitoring that as well. And going forward, you may have future contract negotiations coming up during the year, and you may want to model out whether it's to your advantage to base that on a 2020 Medicare structure or 2021 Medicare structure, depending upon the way that your payers pay. It's important information to know, and it's good information for your contracting staff to understand as they go into these negotiations. So having the ability to model that out really can help them with the negotiation by having some good data for them.
So Scott, putting this all together here, what do you recommend? What would you like to share here?
Well, I think I said it, and I probably should still stress this. The first thing you have to know is how is your Medicare reimbursement going to be impacted. If you're a heavy Medicare practice, you're going to definitely want to make sure that you pull that E&M utilization, pull your total RVUs, revalue those, apply the new conversion factor, and model it all out. Once you have that done, understand how the RVU changes are going to impact other things in your practice. How is it going to impact comp? How is it going to impact your budgets? Make sure that you make the changes that you need based upon expectations of your providers. And then when you're looking at your other payers, understand how this could impact them and ways that maybe you can take advantage of that in future negotiations.
From an analytics side, I talk about this, certainly if you're a customer, you hear me talk about this all the time, re-examining your dashboards, your current reports. Do they still provide context? As things change, are they providing the right information so that departments, divisions, administrators, physicians can manage? Or they actually could start providing misleading information that their productivity is or isn't changing, when in fact we have another thing going on. So always re-examining your dashboard and reports, great opportunity to clean house, tune things, straighten them up, and obviously then make sure you have the right tools in place to monitor the changes. This is a real significant change, and it's unique how Medicare has positioned this, or CMS has positioned this for the Medicare program. So I think making sure that you're monitoring things as they happen rather than reacting when you suddenly find that RVUs are up, but potentially reimbursement or revenue could be down. You don't want to get caught on what's going on. And then finally, are you communicating effectively? Do the people that need to understand the changes, are they able to understand them? Are you giving them timely information? Are you allowing their analytics that you have in your reports and dashboards to communicate what's going on? I do want to highlight for customers, we have 3 additional workshops that were just added to our October training schedule. You can find these on our website under training, and we'll have more information coming out. The first workshop that is tied to today's webinar is using PDS Dash to model the proposed changes. And Scott will be leading us through that Dash model you saw that's actually projecting the revenue, showing you how you can take the template that PDS has designed, and then by applying your analytics to it, you should be able to model out, at least get a good starting point as to the impact of Medicare changes. So that's on October 6th. On October 21st, Kelly Constantinitis and Scott will be sharing, analyzing, and modeling using the PDS utilization and reimbursement cubes on how to model some of the changes in the fee schedules and different ways that you can look at things. If you're using PDS Foundation or Cognos Analytics, any of our customers that have that tool set, certainly welcome to join and learn more about how to model your analytics. And then on October 27th, we've also added a workshop around our PDS Contract Analyzer. If you're one of our customers that uses this module, we'll be showing how to plug in the Medicare fee schedule, make sure you're comfortable with using the tool to get the right results. If you're a PDS customer, you're not familiar with this module, or you're interested in learning more, we'll also be sharing and showing the value of that as well. For those of you on the call that are not familiar with PDS, or PDS is new to you, or you're not currently a customer, we have 3 overview sessions set up, and you're welcome to attend one of these sessions if you'd like to see our tools more, ask questions, or dig into any area of anything that we've talked about today. So those will be on October 8th, 13th, and 26th. And we'll have more information coming out on those tools as well. All right, I think we're going to conclude here. Certainly, if you have other questions or you'd like to learn more about PDS, we'd certainly love to hear from you. Thank you all for attending. Thank you, Scott. Great information you shared today. Appreciate it.
Thanks, everyone. I appreciate your time joining us today.